Now I invite Dr. Smita to talk on anti-glaucoma medications in pregnant, lactating and pediatric patients, which is a common dilemma that we face in our OP. So Dr. Smita works as a consultant glaucoma surgeon in Little Flower Hospital, Angamali. Over to you, Smita.
Good morning all. My topic is anti-glaucoma medications in pregnant, lactating and pediatric patients. Glaucoma is very rare in pregnant ladies. It occurs in about 2 to 3%, and it may be a pre-existing early childhood glaucoma, or it may be associated with other coexisting conditions like uveitis or diabetes. So glaucoma in pregnancy is a challenge to the treating ophthalmologists, as they should keep a balance between the risk of vision loss to the mother as against the potential harm to the fetus, as these drugs will cross the blood placental barrier and reach the fetus and cause teratogenicity. And there are very few evidence-based recommendations seen in literature. And during pregnancy, the IOP decreases. It is more marked in the third trimester, and it persists for several months post-op. The largest IOP decline is seen in 12 to 18 weeks in non-glaucomatous patients, while it is seen in 24 to 38 weeks in ocular hypertensives. About 10% of glaucoma patients progress during pregnancy, so we have to monitor glaucoma during pregnancy. There is a decrease in IOP, and this is due to an increase in the uveoscleral outflow, and progesterones act as a glucocorticoid receptor antagonist in the outflow apparatus, and it inhibits the ocular hypertensive effect of endogenous steroids. There is generalized decrease in the upper extremity venous pressure and peripheral vascular resistance, which decreases the episcleral venous pressure. And the maternal metabolic acidosis also leads to decrease in IOP. FDA has classified these anti-glaucoma medications into 5 categories. Most of the anti-glaucoma medications come in category C, where there is unsure safety. That is, the animal studies have shown evidence of harm to the fetus, but there are no adequate and well-controlled studies in pregnant women. Brimonidine is the only drug which comes under category B, where there is a presumed safety. Animal studies have not shown evidence of harm to the fetus, and there are no adequate and well-controlled studies in pregnant patients. When we administer topical drops, we have to do eyelid closure and nasolacrimal occlusion, as we can decrease the systemic absorption by 60%. Punctal plugging and blotting the excess drops away also helps to reduce the systemic absorption. For the fetal safety, we have to use the fewest number of drops with lowest concentration and least number of times each day. Coming to the teratogenic effects of glaucoma drops, beta blockers have caused intrauterine growth retardation and cardiac conduction defects. Carbonic anhydrase inhibitors can cause oral limb defects in animal studies. Prostaglandin analogs can increase the uterine tone and decrease the perfusion of the fetus, and it can also precipitate miscarriage and premature labor. Parasympathetics like pilocarpine can cause neonatal hypothermia, restlessness, and seizures in newborn. And brimonidine is the safest drug to use during pregnancy. To summarize, brimonidine is the only drug in category B which can be recommended in the first and second trimester. It should be avoided close to delivery because of the neonatal effects. Beta blockers belong to category C, and it can be used in the first and second trimester, but is better avoided in the third trimester because of the risk of neonatal effects. Prostaglandins also belong to category C, and it can be used in the third and possibly in the second trimester because of the risk of early labor. And calcium anhydrase inhibitors, it can be used in the late second and early third trimester. Pilocarpine can be used in all 3 trimesters. And Rho kinase inhibitors, they are not categorized, and they possibly can be used as based on the animal studies. If the IOP is not controlled with medications, then next option is selective laser trabeculoplasty. It can decrease the medication burden or can eliminate the medications, but it is less effective in people less than 40 years, and it requires an open angle. Surgery is another choice if the IOP is not under control, but it is better to avoid in first trimester, and there is risk of anesthesia, so it's better to use topical anesthesia, and use of post-operative medication should be done carefully, and these patients should lie down for supine position for a long time, so it is difficult for these patients. And coming to the medications during lactation, all these medications can can reach the breast milk, and so it can cause harmful effect on the babies. Alpha-adrenergic agonist, that is brimonidine, is contraindicated. It is contraindicated during lactation while it is used in pregnancy. This contraindication is due to risk of CNS depression, lethargy, and bradycardia. This is very important. Beta blockers are safe, but we have to be cautious in infants with cardiopulmonary disease. Prostaglandins are likely safe since they have a short half-life. Pilocarpine safety is unknown as there is risk of cholinergic exposure. Calcium anhydrase inhibitors are safe as they have short half-life. And Rho kinase inhibitors safety is unknown. So the recommendations for glaucoma medication during pregnancy and lactation. During pregnancy, first line of treatment is brimonidine and second line is beta blockers. During lactation, first line is topical carbonic anhydrase inhibitors, alternative is timolol and prostaglandins. In summary, before conception, for those patients who attend in our OPD, who are in the childbearing age, you have to inquire about the pregnancy. They will not volunteer you about the pregnancy. And a discussion of treatment goals, that is target IOP, treatment options, and strategy, that is stopping or changing the current regimen, should be ideally held in pre-conception period. And treatment decisions should be shared with the entire healthcare team, like obstetrician, pediatrician, etc. And close follow-up needed throughout the pregnancy. Identify drops that are safe. Laser therapy can be safely performed during pregnancy and lactation. And drops should be administered with a nasolacrimal occlusion and eyelid closure. And since this passes through the breast milk, it should be given immediately after the feeding session. And coming to the management of pediatric glaucoma, surgery is the mainstay of treatment, as in primary congenital glaucoma and glaucoma associated with ocular anomalies. Medication is given as a temporary measure to clear the cornea to allow goniotomy, awaiting surgical clearance, post-op, etc. And long-term or permanent medical treatment when the target IOP is achieved without surgery, and in cases of secondary glaucomas like post-traumatic glaucoma, post-cataract surgery, steroid-induced glaucoma, etc., we can give medical management. And there is very high risk, if the patient is very high risk for surgery with moderate increased IOP, and if the patient is unwilling or unfit for surgery, and palliative treatment in non-seeing eyes, and post-op after successful surgery. This is an article in Journal of Current Glaucoma Practice, where medical treatment is successful in about 53% of secondary glaucoma. And another article in IJO about the profile of childhood glaucoma at tertiary center in South India showed a significant patients were treated with medical management, and it is effective. And coming to the Graves Archive, that is a review article on the medical management of pediatric glaucoma, lessons learned from randomized controlled trial. There are very few RCTs in pediatric glaucoma because of the safety and ethical concerns. They have the IOP lowering efficacy similar to that of the adults, as in 25% with timolol. And latanoprost, it is about 26, and travoprost, it is 27. And coming to the responder rate, it is less responding compared to that of the adults. With timolol, it is 47%, latanoprost is 60, and travoprost 83%. So the efficacy is similar to adults. Responders, they are less than in adults, and they have high systemic absorption. The systemic absorption of topical timolol is similar to that of the oral or IV administration. They should be careful when giving topical timolol, since the blood retinal and blood-brain barriers are not fully developed. There is a small volume of plasma and lower concentration of principal plasma binding protein. So we have to use the lowest dose, preferably gel formation and lacrimal punctal occlusion. Beta blockers can be given, and the mean IOP is 20 to 25%, and it should be avoided in premature and small infants. Prostaglandins have good efficacy. Carbonic anhydrase can be used as a first or second line therapy in young children. Rimonidine is contraindicated in children less than 6 years, weight loss less than 20 kg. Children with CNS depression or CNS response cannot be assessed. So medical treatment of pediatric glaucoma, there is low medical adherence is seen. This is a challenge. So barriers to medication adherence include forgetfulness, complex dosing regimen, and being too busy with other activities. So monitoring of the pediatric glaucoma patients is important. Proper and timely monitoring is necessary for the best outcome. General examination should include all the vital signs and alertness, especially in beta blockers and brimonidine. Parents should be asked for the adverse reactions, and detailed ocular examination like IOP, corneal clarity, and optic nerve head examination should be done, and examination under anesthesia may be needed in some cases. Thank you.
Thank you, Dr. Smita, for that wonderful presentation.